Jamuted. Jabated. Welcome to another Healthy Gamer GG stream. My name is Alok Kanoja. I'm a psychiatrist, but just a reminder that although I'm a psychiatrist, nothing we're going to be discussing today is intended to be taken as medical advice, and everything is for educational or entertainment purposes only. So welcome to another Healthy Gamer GG stream, everyone. Hope y'all are doing well. Hope y'all had a good weekend. Plan this week is to stream once again 4 days this week. So I think we've got Monday, Wednesday, Friday streams, and we've got our group, our content creator group stream on Thursday afternoon. So check that out. That's something new that we're trying. And thank you everyone who has subbed, donated, etc. Even Twitch Prime subs and things like that go a long way in helping us build content. Basically funds things that we're trying to do in terms of improving the quality of our videos, uploads, graphics, things like that. So thank y'all very much for everyone who's supported. As you all see, we have a nifty new, we update our graphics from time to time, functions, bots, etc. So thank y'all very much for supporting the stream. We really appreciate it. Every little bit helps. So we are on our last week of the Swap It Challenge. So for people who don't know, we have an awesome community challenge that we're doing right now, which is the goal of which is to swap out negative and kind of useless technology habits with healthier alternatives. So we're in our final week, week 4 of our Swap It Challenge, and the goal is to swap out bad habits for good ones. And every swap that we do contributes to our community pool, and then as our community pool hits particular milestones, we will actually have particular community things. So we've already hit our 500,000 point milestone. So there's a special role for participants. We hit our 1 million, I think, point milestone last week, which is a Saturday of jam-packed events on Discord. And we're about 65% of the way to the 2 million point milestone, which will be a bedtime ASMR stream. The top 5 contributors will also get $50 of store merch and access to Dr. K's Guide to Mental Health. So the way this works is we're on week 4. And so a lot of times if you look at sort of habit formation, one of the challenges is that we can be very, very gung-ho at the beginning, right? We're like so excited and we're like, okay, I'm going to like work out and I'm going to eat healthy. I'm going to do all these things. But if you look at the science of habit formation, one thing that we know is that generally speaking, we want to build habits over time, and we want to target consistency. So key part of the challenge is that on week 1, you could only swap out a maximum of 5 minutes worth of stuff. And every week we're sort of building longer duration habits and sort of swapping out more and more negative stuff in our life. So this is week number 4, and we've got 30 minutes of swapping out that can happen. So if y'all are interested, by all means, join the Discord, hop on, start swapping out negative technology habits, whether it's, wasting time on your phone first thing in the morning or, spending too long in the bathroom because you're scrolling through stuff, etc. Like whatever it is. So swap something negative out for something positive. There's a list of suggested activities that we've got. People will sort of share their experiences. And as you swap things out, take a picture of it, submit it. Doesn't have to include your face or anything like that. Okay, so it's just part of a really cool thing that's been going on in our community recently where we're actually doing stuff, right? So there's talking about stuff and there's doing stuff. And at this point, our community has learned so much. We've leveled up to the point of actually doing things. I know the bathroom scrolling thing tends to get people all bent out of shape, but it's really important. You'll be surprised at how much more time you get in the day. Okay, so today we're going to go over a couple of posts, but we're going to talk a little bit about depression, and we're also going to talk a little bit about SSRIs. So we're going to do sort of like more mental health 101 kind of education. So we're going to teach a little bit about antidepressant medication, what the deal is, what the controversy is, does it work, does it not work? There was recently a paper that came out in Nature that suggested that the neurochemical imbalance hypothesis of depressive episodes in clinical depression is not really supported by evidence. That created a lot of hubbub, so we're going to talk a little bit about that, but then we're going to be talking a little bit about the role of antidepressant medication and kind of like how it works, why we use it, as well as address a couple of really common questions about if I start antidepressant medication, is it going to be a happy pill? Am I going to be kind of like stuck on it for the rest of my life? Like, how does all that stuff work? So we're going to just jump into okay. My OS is messing with me. So we're going to jump into a little bit about antidepressants. So let's talk a little bit about antidepressants and specifically SSRI medications. So the first thing to understand is that there's a clinical illness called major depressive disorder, unipolar disorder, depressive disorder, bipolar disorder. So these are mood disorders. So these are like fluctuations of our mood that tend to be so severe that they cause some kind of impairment in function. So everyone experiences sadness, everyone has low energy kind of days. But what we've noticed in the field of medicine is that for some people, these symptoms are very persistent. So they'll last for weeks, months, or even up to a year or over a year at a time. And that they're so bad that they make it difficult to live a normal life. So it's difficult to engage in social relationships, difficult to get your work done, difficult to go to school. You'll sort of experience negative things like energetically. So like your body can feel heavy. It can feel really hard to get out of bed. Other features of mood disorders and depressive episodes are changes to your sleep. So sometimes people will sleep too much, 14 hours a day, 15 hours a day. Sometimes people will sleep too little. They'll wake up at 4 a.m. every single day, like with their mind being very anxious and have trouble going back to sleep. So we know that there are clinically present, this exists, that depression is some kind of illness. We also know that it tends to strike particular people. So a key thing about mood disorders is that they're episodic in nature. So I'm doing fine freshman year. Sophomore year rolls around, my second year of uni rolls around, and suddenly like I have trouble getting out of bed, et cetera, et cetera. It stays bad for a while, but the other thing about depressive episodes is that they tend to resolve over time. So one thing to remember is that depressive episodes are not necessarily a diagnosis. So you can have a depressive episode as part of a major depressive disorder or a bipolar disorder or related to other things. What we're going to be talking about today is a little bit about SSRIs or antidepressant medication, how they work, what they do, and what their limitations are. So before we dive into this, one thing that I want to share with y'all is a paper that came out recently from the journal Nature, which is a very high impact factor journal. So high impact factor means that it tends to be cited a lot. Generally speaking, it's a high quality journal with high quality evidence. And a paper came out recently that suggested that the serotonin theory of depression is actually somewhat false. So for a long time, people have been saying that major depressive disorder and bipolar disorder and depressive episodes are caused by a neurochemical imbalance and a deficiency of serotonin in the brain. And what this paper basically demonstrates is that the quality of evidence that suggests that there is a neurochemical imbalance in the brain that causes depression suggests that the quality of evidence is like low or inconsistent. And the paper basically makes the argument that actually this neurochemical imbalance theory is essentially false. So this is important to understand for a number of reasons. So the first thing is when this paper came out, there was a lot of popular media interest in it because people were sort of saying, oh, like the neurochemical imbalance theory is false. And then they would interpret that statement in a number of different ways. So that one of the primary interpretations is that if the neurochemical imbalance theory is false, that means that antidepressant medication doesn't work, or that we've been scammed for the last 30 years by big pharma and drug companies that have been peddling this medication that is based on a theory that is actually incorrect. So we're going to talk a little bit. I don't really think that that's a fair interpretation. We're going to talk a little bit about that. But let's first talk a little bit about the neurochemical hypothesis of depression. So basically, in the 70s and 80s, psychiatry experienced somewhat of a revolution. And we discovered that there were actually there was a biological side to psychiatry. So prior to the 1970s and 1980s, psychiatry was primarily a psychological discipline. So it was like Freud talking to people, interpreting things about the subconscious, et cetera, et cetera. And as medical advances improved, psychiatry sort of developed this kind of biological side, which means that there's neurochemicals involved, there are medications involved. And when fluoxetine, the first antidepressant or SSRI, came out, people thought it was pretty revolutionary because for the last 100 years, we really haven't had medication treatments for things like clinical depression. And suddenly we've got one and it seems to work really well. So it's important to understand, though, that when we developed antidepressant medication, we did not develop antidepressant medication as a response to understanding the mechanisms of depression. So it wasn't like we figured out, oh, by the way, depression is caused by a deficiency of serotonin. Let's try to fix that deficiency of serotonin with a medication. What actually happens usually in medicine, which a lot of people don't realize, is we don't really know why a medication works. We just sort of know that it works, okay? So we'll try a lot of different things. We'll do clinical trials. Some of these things are based on herbs and stuff like that. So we'll know historically, for example, that we have an herb called St. John's wort, which has been shown to be clinically effective for mild to moderate depression. We'll kind of study St. John's wort. We'll see okay, what's the chemical compound that's responsible? Oh, it seems like the chemical compound that's responsible boosts serotonin. So let's see if we can isolate it, purify it, et cetera, et cetera. So one thing that kind of happened early on is we studied SSRIs and we sort of realized that they're somewhat efficacious, and we'll get to that in a little bit. So we discovered antidepressant medication works. And then what happened is there was this big movement to destigmatize mental illness. Because prior to this, mental illness was basically viewed as a personal deficiency, right? If you have trouble getting out of bed because you're depressed, that's just laziness. And so one of the key things that was very, very helpful in destigmatizing mental illness was this neurochemical imbalance hypothesis. Oh, it's not your fault. You're not lazy. You just have a neurochemical imbalance. And by the way, we have clinical trials that show that antidepressant medication works. So the interesting thing about the neurochemical imbalance hypothesis of depression is that I don't think that psychiatrists or scientists, if the people who are really educated, really ever had or necessarily believed that, neurochemical imbalances cause depression. And the key thing to remember is that neurotransmitters do all kinds of stuff in our bodies, right? So we sort of think about, popularly, we'll sort of associate dopamine with pleasure. We'll associate serotonin with mood. And there are some connections, but remember that serotonin and dopamine do all kinds of different things. So Parkinson's disease, which is a disease that affects dopaminergic neurons in our brain, makes it difficult for us to walk, right? So our motor movement, anytime I move my hands, that's governed by dopamine. A lot of our peristalsis, so the ability of food to pass through our GI system, that's actually also controlled by serotonin. So serotonin does a lot of different stuff. And just because the neurochemical imbalance sort of theory may not be as strong or may even be false, does not actually say anything about the efficacy of antidepressant medication. Because we have clinical trials that even if we don't know how it works, we still have evidence that SSRIs or antidepressant medication are effective for depression. So this is one distinction or nuance that I think has been completely lost in the common media, right? So we don't know exactly, and we'll get to the mechanisms of action, explain why, even though there may not be a neurochemical imbalance, how boosting your serotonin in the synaptic cleft can still be helpful for depression. So we're going to take a step back and just let's recap, okay? So for a long time, recently actually, people have thought that depression is based on a neurochemical imbalance. We also know that boosting serotonin seems to improve symptoms of depression. And actually a key thing there is that remember that the hypothesis of neurochemical imbalance has actually grown a lot more after we started using antidepressants or SSRIs. And what people basically did is reverse engineer that hypothesis and sort of concluded that, okay, if I boost someone's serotonin, if they start to get better, then that must mean that serotonin is deficient in the brain. But it actually turns out that that really isn't the case. So let's dive in and try to understand a little bit about antidepressant medication and kind of how it works. So here's just a Google search for the synaptic cleft. Okay, so what we can do is kind of look at, you know, pictures of, I don't know what this is, but the synaptic cleft. So let's try to understand how antidepressants or SSRIs work. So this is something called a synaptic cleft, which is where two neurons or nerve cells meet. And in the end of one neuron, we have these little things called synaptic vesicles. So these are little packages of neurotransmitter. And generally speaking, what happens is when this neuron activates with an activation potential, we'll get the vesicle kind of merges with the synaptic cleft and dumps out the serotonin. The serotonin floats across this gap and activates some stuff in this receptor. So this is kind of how a synaptic cleft works. Over time, these molecules will then get taken back up into the cell, so they'll kind of return where they came from, get repackaged into vesicles, and essentially recycled. So we'll send out a signal, and then we'll kind of recycle it. So the most common antidepressant medication is called a SSRI, which means selective serotonin reuptake inhibitor. So essentially what an SSRI does is blocks this receptor. And when we block this receptor, this stuff can't go back into the cell and floats around longer and increases the signal over here. Okay? So it essentially boosts the serotonin transmission signal in the synaptic cleft, thus effectively increasing the serotonin signal between two neurons. And when we use this kind of drug, essentially what we discover is that people with depression seem to get better. Oh. Wow. That was, oh. Okay, there we go. People seem to get better. And so the interesting thing to know, though, about SSRIs is that it's not a direct serotonergic kind of boost that results in the improvement that the drugs give. So when we sort of, I'll just say that sentence again. So people sort of think about serotonin as kind of like a direct dose response sort of effect. And what does that mean? So if we think about like other kinds of neuroactive substances like alcohol, what we sort of think of is that, okay, once if I have 1 drink versus 2 drinks versus 3 drinks versus 4 drinks, the more drinks I get, the more intoxicated I become. But it turns out that the action of SSRIs or antidepressant medication is actually a little bit different. So it's not like doubling our serotonin doubles our happiness. If we look at the mechanism of SSRIs, what we discover is that they create a lot of cellular machinery changes. So it's like boosting the serotonin signal doesn't make us twice as happy. What it actually does is turns on some machinery within our cells. So it activates gene transcription. So our cells start producing more machinery. It affects our receptors. So the effect is a little bit more long-term. What does that mean practically? What it means practically is that when you take an SSRI, it's not like alcohol, where if I drink 3 shots of alcohol over the course of 3 hours, that I will notice the effect right away. In fact, the studies on SSRIs show that SSRIs take anywhere between 1 week and 8 weeks to work. So this is something that's really important to remember about antidepressant medication is if I feel super depressed and I take it today, tomorrow, and the next day, I may not notice any kind of effect. And why is that? It's because it's not a direct boost to serotonin. It's because we're turning on certain cellular machinery. We're activating particular genes. So for example, one of the things that we know is that SSRIs create more proteins that are neuroprotective for our brains. So they'll create these kind of protective proteins in our brain, and those may take time to work. So the action of SSRIs and antidepressant medication is actually weeks. So this is important to understand because if you start an SSRI or antidepressant medication, you may not notice a benefit right away. This becomes doubly important because sometimes the side effects of antidepressant medication we do notice right away. So for example, people will sometimes feel a little bit nauseous or have some upset stomach. And that's because, remember, serotonin is in our gut as well. And as we boost serotonin transmission, we can sort of mess up our tummy a little bit. But the key thing to remember about antidepressant medication is that it can actually take weeks to work. And so even if you're not really seeing a benefit right away, that's actually perfectly okay. It can take a couple weeks. So let's try to understand a little bit about the efficacy of antidepressant medication. So a lot of people will be kind of, curious or concerned about how effective antidepressant medication is. People will be concerned that they'll be hooked on it and that it sort of is a happy pill and sort of creates an artificial sense of happiness. Whereas the truth is that really isn't the case. So people have also been concerned that, there's an overprescription of antidepressant medication, especially during things like the pandemic, and that essentially big pharma is trying to get everyone to take antidepressants. And they may be getting everyone to try to take antidepressants. I can't really comment on what they're doing or not doing. But the good news is that the data for SSRIs and antidepressants is pretty good, right? So we know, for example, that if you start an SSRI, that you can expect somewhere between a 30 and 50% improvement in your depressive symptoms over the course of 1 to 8 weeks. So it's not going to make you magically happy. By the way, SSRIs are not drugs of abuse. So a lot of people will think that if I improve my depression, it's like making me happy. It doesn't make you happy. It really seems to resolve the depression. But it's not like SSRIs create any kind of euphoria. You don't hear, SSRIs don't have any street value. People aren't abusing them because they actually are happy pills. Those are substances of abuse, things like amphetamines, cocaine, even alcohol, benzodiazepines, marijuana, so SSRIs really aren't happy pills. What they really seem to do is reduce the frequency and severity of depressive episodes. So what we know is that when people start them, you'll get sort of a 30 to 50% improvement in depression. Now, the other thing that I kind of want to point out is that as we've done more and more studies on SSRIs, what we've sort of found is that the effect of SSRIs seems to be smaller than we originally thought, and that the effect of SSRIs is a little bit more complicated than we sort of understood. So here's just one example of kind of the nuances of antidepressant medication. And this is a good example of how antidepressant medication, a lot of it seems to be based on belief. So as people are more hopeless, or if they think that an SSRI will not work, it actually reduces the efficacy of the SSRI. So some people have even hypothesized that 70% or up to 70% of the therapeutic value, the clinical benefit of an antidepressant medication is actually placebo, and only 30% of it is biological. Now, if I say something like that, y'all may be very, very surprised, because you may say, well, if it's placebo, does that mean that it's not effective and I shouldn't take it? Whereas not necessarily. In fact, what we sort of know is that even if it's placebo, we sort of still know that it works. And there are even studies that show that if you tell a patient this is a placebo, but you also tell a patient that placebos lead to clinical improvement, giving that person that medication, even though they believe it's a placebo, if you tell them, hey, I think this SSRI is going to help you, even if it's a placebo, it turns out that it actually works and it helps them. So knowing that something is a placebo doesn't actually remove its effect, as long as the patient understands that placebos can actually be helpful. So we sort of know that SSRIs may not be quite as efficacious as we thought. So here's kind of my clinical experience on it. So what I'd sort of say is when we look at a 30 to 50% improvement, which is what most of the meta-analyses show about antidepressant medication, what we discover is that that's an average, right? So we'll take 100 people, and on average, we see a 40% improvement. But more specifically, if you're a clinician, and we saw this a lot during COVID, what you actually see is that it's not actually a 40% improvement for all 100 people. That people actually fall into 3 camps. So for about a third of people, SSRIs are very, very effective. So we're talking 70% improvement, 80% improvement, 90% improvement, really kicks the depression to the curb. For about a third of people, they're like moderately to mildly helpful. We'll see that sort of 30 to 50% range. It does seem to help, but it doesn't really cure my depression. And for about a third of people, it really doesn't seem to help at all. And this is what we've seen a lot as we've sort of seen the nature of depression changing, is that a lot of depression now seems to be very circumstantial or existential in nature. So I'm like, COVID is happening, I lost my job, there's inflation, there's climate change, all these kind of existential factors. If those are leading to our depression, it seems that SSRIs are not really effective at helping that. The key thing to remember here is that 30 to 50% number is probably due to multiple different kinds of depression within a population, and that antidepressant medication is very, very helpful for about a third of people. And for the other third of people, it helps some. So we're still talking about a success rate for about, let's say, 2/3 of patients in my clinical practice. That's kind of what I'd say historically that I've seen. But that's another important nuance. So the last thing that we're going to talk a little bit about in terms of antidepressants is a lot of people are really curious or concerned that if I start an antidepressant medication, am I going to be stuck on it? Is this the kind of thing that I will then be dependent on as a happy pill? And the evidence here is actually like pretty interesting. So it turns out that if you start someone on an antidepressant medication, they should stay on it for probably about a year. So for a lot of people who go off of antidepressant medications, about 50 to 60% of people who go off of antidepressant medication will, depending on how they go off and what other kinds of things that they do, they'll experience depression again later in life. So within about 1 to 2 years, about 50%, let's say half of people who go off of antidepressant medication will be depressed at kind of 2 years out. But what that also means is that about half of people actually, even if they'll really only need SSRIs once in their life, and then they'll kind of be okay after that. So in no way is an antidepressant medication something that you'll become dependent on. For the people who require antidepressant medication for longer periods of time, these are people who tend to experience frequent or severe depressive episodes. So remember that a depressive episode it's an episode, so it's kind of time limited. So generally speaking, the people who are on SSRIs long-term are the ones that will tend to get depressed over and over and over again. And this is also important to remember about SSRIs or antidepressant medication, is that it kind of reduces the severity and frequency and duration of episodes. So if you're someone who struggles with depression and you're on an SSRI versus not on an SSRI, you're less likely to get depressed in the first place. If you do get depressed, the severity of that depression, it won't be as bad, and you'll stay depressed less, right? So like one person may be severely depressed for 8 months, and they'll get 1 episode of depression a year, versus someone who's on an SSRI may get depressed once every 3 years for a period of 2 to 3 months, and it won't kind of be as impairing. So the goals of SSRI treatment are really sort of reductions of duration, frequency, and severity of depressive episodes. Now, the other thing to remember about SSRIs is that they oftentimes do have side effects. The good news is that side effect profiles for SSRIs are some of the best tolerated in medicine. That's part of the reason why we sort of prescribe them as much as we do, because most people will take an SSRI and not even notice anything. They may have a couple of days of like some sort of change, maybe like a little bit of fogginess, a little bit of headache, a little bit of upset stomach, but that tends to go away within a week, so they tend to be tolerated really, really well. One other thing to remember about SSRIs, and this is where a lot of people run into problems, is that you have to be a little bit careful about coming off of SSRIs. So a lot of times what patients will do is they'll take the SSRI when they're very depressed, because they'll do anything to get out of the depression. They'll start to feel better 2 or 3 months later, and they'll be like, I feel fine every day. I don't need to take this medication. They'll kind of stop it. So that's something that you should definitely talk to your doctor about, because there's some evidence that shows that SSRIs need to be tapered. So you can't just kind of quit cold turkey. I mean, you can, but you really shouldn't. You should really sort of go off it sort of smoothly. And when you taper it properly, it also helps in terms of not having a relapse of your depression. And you also have to consider that sometimes the reason that you're feeling good every day is because you're on the medication, right? So this is sort of like someone who's like, wow, I feel really healthy because I'm eating healthy every single day, and I feel really fit, and I have tons of energy because I'm working out, and I'm eating healthy every single day. And so because I'm healthy now, I no longer need to exercise or eat healthy, right? So something you have to really remember about antidepressant medication is if it helped you get to where you are, you may want to consider staying on it for a little bit longer, or at least talk to your doctor about it. As always, when it comes to details of, okay, do SSRIs work for me or not work for me? You know, should I use them? Should I not use them? Here are my concerns. You should always talk to a doctor about starting them, stopping them. Talk to your doctor. I think it's very, very common as psychiatrists. We hear all the time that people don't want to be on their SSRI. So it's absolutely something that you can do in sort of like a low risk fashion, right? So you want to be monitored as you come off of it to make sure that symptoms don't reemerge. And there are other things that you can start to do instead of SSRIs that will sort of keep you mentally healthy. So that's kind of our brief discussion of SSRIs or antidepressants. we started off talking a little bit about the neurochemical imbalance hypothesis and some of the associations that people make with that. So there's a recent research that shows that depression is not actually clinical. Depression is not actually caused by a neurochemical imbalance. And so a lot of people will interpret that as, oh my God, that means that antidepressants don't work. Whereas the truth of the matter is that we don't really know sometimes why our medication works in medicine. And every day that goes by, we discover some new effect of a medication. We'll discover off-label uses. It turns out that SSRIs are also helpful for anxiety. We didn't really know that originally. But what we do know is that SSRIs and antidepressant medication does seem to be effective. And those clinical trials haven't changed just because depression may not be caused by a neurochemical imbalance. We also know that SSRIs tend to take some time to work. So we're talking somewhere between 1 to 8 weeks to reach full efficacy. And we also know that sometimes people do need to be on SSRIs for extended periods of time, sometimes 2 years, 3 years, 4 years. But that a lot of people can actually safely come off of SSRIs and you're not going to be dependent on it for the rest of your life. So hopefully that's kind of useful. Hopefully it's sort of a quick introduction to antidepressant medication, how it works, how it doesn't work. And, by all means, if you're interested, talk to your doctor about it. Questions? Okay, so someone's asking about thoughts about someone who has PTSD and depression who SSRIs don't work for. So there are a couple of things to understand about SSRIs in terms of when they, quote unquote, don't work. So the most common reason, actually, I don't know about the most common reason, but one of the most common reasons that SSRIs don't work, quote unquote, is because there is another thing going on that interferes with the efficacy of the SSRI. So a good example of this is something that we call dual diagnosis in psychiatry. So we made some interesting observations as clinicians that when someone has, let's say, a substance use disorder, like they're addicted to alcohol or marijuana, and they have depression, that you can't treat one of those on its own. So for example, if I start someone who has an alcohol problem on an SSRI or antidepressant medication, that may help some, but the alcohol itself, if I'm drinking every day, that's going to cause depression. So we know, for example, that alcohol can induce a depressive episode. So we know that alcohol kind of makes us kind of feel down on ourselves, can sort of acts as a CNS, a central nervous system depressant. It literally like slows down the transmission in our brains. And so as long as we're sort of drinking, the SSRI doesn't seem to work. The other thing that we know is that when people are alcoholics and they have an untreated depression, that can make it hard to become sober. So I use alcohol as a coping mechanism and I become sober for, let's say, 6 months, and then the depression kicks in. So even though I've been sober, I have a separate process going on that makes me feel depressed. And until I sort of take care of that process, when I start to feel really, really depressed and down on myself, what do I start doing? I start drinking. So what we know from dual diagnosis is that you can't sort of tackle one problem at a time, and that good treatment actually involves sort of addressing the depression, because if you get depressed, you're going to start drinking, and addressing the alcohol use, because if I start drinking, I'm going to get depressed, right? So if I start drinking, I get written up at work, people get upset with me in my personal life, that lowers my mood, makes me feel depression, can kind of trigger a depressive episode. So for people who have multiple diagnoses, I would be super careful about thinking that something, quote unquote, doesn't work. Probably what you need is treatment for both diagnoses simultaneously for that antidepressant medication to work. That being said, remember that sometimes, especially when it comes to trauma illnesses, trauma can be sort of the great masquerader. So it's like the great chameleon. And trauma can look like all kinds of other things. So sometimes I've seen people who are, get diagnosed with a major depressive disorder or unipolar depression or bipolar depression. And actually what they've got is some form of PTSD or complex PTSD or something like that, which can look like depression. So trauma, you've got to be really, really careful about, because it can really interfere with all kinds of stuff and even look like all kinds of stuff. You may not even have depression. You may just have trauma that looks like depression. So I wouldn't give up on SSRIs, just because you had a trial and it sort of didn't work. I would really think a little bit about getting into good treatment that tackles kind of everything at the same time, sort of a comprehensive, personalized treatment plan with like a really good medical team, doctor, and really then sort of determine whether SSRIs work or don't work. A couple of other things to keep in mind. There have been studies that show that even if the first SSRI or antidepressant that you try doesn't work, that about half of people will see a good response from their second trial of an SSRI. So if you've tried one and it didn't work and you try another, there's about a 50% chance that that'll actually work well. The more trials that you have, the lower your success rate is. So for your third trial, maybe about 20% of people see a pretty good benefit from it. And so there are people for whom SSRIs don't seem to be very effective. And we kind of know that. Great question. Yeah, so Ukulele is talking about, there's a really interesting black box warning here in the United States that starting an antidepressant medication actually increases the risk of suicidality in younger adults or teenagers. So there's kind of this idea, or not idea, we know. Okay. Can you close the door, sweetie? Okay, thanks. So there was an observation that teenagers and young adults who get started on antidepressant medication for a brief period of time actually have a higher increase, an increased risk of suicidality and suicidal behavior. So this is a really interesting black box warning. I think there's a lot of complexity to it. And there are kind of two, I think, prevailing theories that I put stock in. The first is, from a public health standpoint, let's start by sort of saying that just because you started an SSRI, be aware that you may actually get increased feelings of suicidality or suicidal behavior. So it's just something to watch out for, and it tends to be like a temporary effect. We'll talk about why that is. So it's not like it'll increase it over time. It's for a brief period of time, it sort of increases it, and then the suicidality actually goes down and gets better over time. So why could this be? There are two primary reasons that I sort of think of, right? So these are not necessarily correct. They're just based on my clinical experience and all the evidence I've read. This is sort of where I put my money. The first is that there is a selection bias with severity of illness and starting an SSRI. So if you think about, if I take, let's say, 100 teenagers who are 16 years old, who are all suffering from depression, who is the most likely to get started on a medication? The more severe the illness, the greater the likelihood that you'll get started on medication. So if I take that 100, teenagers who are 16 years old, and I split them into three groups, a third of people are severely depressed, a third of people are moderately depressed, and a third of people are mildly depressed. They all go see a doctor. And so the people with mild depression, they don't get started on SSRI because their depression is pretty mild. Oh, it doesn't seem that bad. I don't need to start you on medication. The moderate people, some of them get started, some of them don't get started. And then the severe people, they all get started. And now what we do is we compare these groups. So what is the likelihood of suicidal behavior in the severe people? It's actually higher than the mild people. So the third of people who all got SSRIs have more suicidal behavior than people who got no SSRIs. Then what we start to do is potentially create a causal link. Does the SSRI cause suicidal behavior? Or is it a selection bias? Does that kind of make sense? So that could be one reason for it. The second reason, which is kind of interesting, is that the way in which SSRIs help us is the different dimensions that antidepressant medication affects work at different timelines. So I know that doesn't make a whole lot of sense, but let's just take a look at this for a second. So if I take someone who's depressed, remember that an SSRI takes up to 8 weeks to work. So what we tend to see practically when we give someone an SSRI is all of their symptoms don't get better all at the same time. So depression manifests as low energy, suicidality, anhedonia, which is the inability to experience pleasure, sleep problems, appetite problems. And what we tend to see is that not all of these things get better altogether. And so sometimes what actually happens is the energy level actually increases first. So people will start sleeping better, they'll start eating better, they'll have a little bit more energy. And some of the more cognitive stuff, like the suicidality, the feelings of guilt, the feelings of shame, some of that stuff takes longer to get better. So what some people have hypothesized is that we actually see a boost of energy before we see improvement in the suicidal thinking. So if I have two suicidal individuals, and one of them has low energy and one of them has high energy, who is more likely to commit suicide or try to engage in suicidal behavior? It turns out that maybe the high energy individual is actually more prone to engage in suicidal behavior. So one of the really interesting theories about the black box warning is that it actually boosts the energy of people who are still actively suicidal, which actually, like, it kind of bizarrely, in their low energy level is actually protective against actually trying to commit suicide. So this could be another reason for the black box warning. We don't really have a very clear answer. I think both of these are really, really sort of reasonable hypotheses. And the key thing to remember is that when you're starting an SSRI, just to be aware, especially if you're on the younger side, so as an adolescent or young adult, you may actually experience more suicidality. This, once again, is exactly why y'all should talk to doctors about it, because there are going to be a ton of other things to consider in terms of side effects and stuff like that. Great question. So some people are saying, is it normal to feel like you're emotionally flatlining when taking an SSRI? I wasn't sad, but I also wasn't happy. I barely felt anything. I'm not sure if it was because of meds not being suitable for me or if it's normal. So the answer is that some people do experience some amount of emotional dulling from the SSRI. This is where just because it happens with one SSRI doesn't necessarily mean it happens with another SSRI. And remember that SSRI treatment doesn't have to be lifelong. So as a clinician, when I work with patients like this, the right move, quote unquote, is very, very individualized. So the first question is, even if you feel emotionally kind of flat, is it helping you in the ways that you need to be helped right now? So that's one question that I'll ask kind of all my patients, right? It's a risk benefit. Anytime you're starting a medication, it's always about risk benefit. Okay, well, you're on probation for missing too many days of work. And even if you feel kind of emotionally flatlined a little bit, like it's helping you work, it's increasing your energy level, you're able to, exercise again and eat healthy again and things like that. Based on the risk benefit, you may want to continue it, even though it's causing some degree of emotional numbness. And we'll see what happens with the emotional numbness over time. Because I've also seen people will sort of adjust to side effects. The side effects tend to hit early and get better over time, whereas the therapeutic benefit from an SSRI starts low and goes slow. The second thing is that sometimes you can switch to a different SSRI where they won't have this effect. And the third thing to consider is that even if it does have the effect and it's kind of helping you, it's not like you have to stay on it forever, right? So remember that a lot of times people will transition off of SSRIs. I'm generally speaking very supportive of patients who want to transition off of SSRIs after a period of about a year and a half. And so it's just a question of risk benefit. Is the emotional numbness worth the functional improvement? The other thing to remember is that the emotional flatlining with an SSRI, I wouldn't necessarily call it common. I would actually say, 70 to 90% of people that I've prescribed antidepressants to basically are fine and don't have any symptoms that are or side effects that are so impairing that they want to come off of medication, but some people do experience it. It is a known side effect. Okay, there's a lot of good questions. Wow. Is it safe to be on long term? That's a great question. So the short answer is we think so. The good news about antidepressant medication is that we've been prescribing it now for about 40 years. And so what we've seen is a generation of people that were started on SSRIs, and some of them have stayed on SSRIs for 3 or 4 decades. And they seem to be doing okay, right? So we don't have any huge red flags, at least at the population level, that SSRI treatment is very, very harmful for most people. So we're pretty confident that it, generally speaking, is safe. That being said, we do know that there are case reports of people who will be on SSRIs and kind of come off of them and like have these weird kinds of symptoms and stuff like that. We also do have evidence that at the neurochemical level, that long-term SSRI use for some people does seem to alter your synaptic chemistry. So it can alter sort of serotonin levels, serotonin receptor levels, things like that over time. But do those alterations result in any clinically significant side effects or dependencies? There isn't really great evidence for that. That to me sort of makes sense. I mean, anything, if you take a medication for 30 or 40 years, there are going to be some kind of adaptive changes in your body. On average, though, we don't seem to, be very concerned, or there isn't really something like on the public health level that makes us concerned that SSRIs are like dangerous or harmful if taken long term. That being said, my personal philosophy as a physician is like try to reduce your medication load as much as possible. There's also evidence, for example, that relapse rates for depression are lower in people who go through psychotherapy than they are for people who use medication management. So that's important to understand. So if I take two patients and I give one of them psychotherapy and I give one of them medication, even though the effect of the two is the same over the short term, so they both improve depression by about the same amount. Let's say psychotherapy and medication both reduce depression by 50%, just ballpark. What we do know is that relapse rates 2 years out and 5 years out are lower for people who have undergone psychotherapy compared to people who started medication and then stopped it. So generally speaking, it seems like psychotherapy, which teaches you certain skills, right? So it teaches you like coping skills, cognitive reframing skills, and those skills stay with you even afterward. And so there does seem to be some evidence that psychotherapy is more effective long-term compared to medication, even when both treatments have been stopped. Great question. So Rock and Roll is asking another good question. How do you distinguish depression from unhappiness and a crappy life? So that's why clinical stuff is important. So thank you, Shino Zeno, for the $100 donation. We really appreciate it. How do you tell the difference between depression and being unhappy? This is exactly why we have clinical scales and tools and clinical training. Because, getting out of bed every day and being depressed, is this my life? Is it that I genuinely don't have a life that's worth living? Or is this like a clinical illness? I don't know. This is exactly why we have clinical assessment tools. And the good news is that we have particular, forms of assessment, which will differentiate whether you actually have a mood disorder or you're just unhappy. The good news is that therapists or psychiatrists, generally speaking, can help you with both, right? They can help people with unhappiness. But this is why if we look at the diagnostic criteria of depression, there are some things that are a little bit different between being unhappy and being depressed. So for example, some highly specific features of mood disorders are things like early morning awakenings. So if you wake up at 4 to 5 a.m. every day, despite going to bed at midnight and can't go back to sleep and your mind is racing, that generally doesn't happen to people who are unhappy. So people who are unhappy may have difficulty falling asleep, but generally speaking, once they fall asleep, they'll kind of pass out and kind of wake up. We also know that anhedonia is common in people who have depression versus people who are unhappy. So people who are unhappy can usually still get enjoyment out of doing stuff that they normally enjoy. Even though my life is not great, I still enjoy going out with friends. I still enjoy seeing a movie. I can go see a movie and I'll have a good time. Whereas in clinical depression, we'll see more anhedonia. That's getting especially tricky nowadays. And I think the reason this question has become so tricky is because as we become a more dopaminergic society, we're starting to see more anhedonia in normal people. So 30 years ago, anhedonia used to be a good way to differentiate between clinical and non-clinical depression, right? So is it am I unhappy or am I clinically depressed? But the inability to experience pleasure is happening more and more the more dopaminergic our society becomes. As we get bombarded with dopamine, everything feels less fun. And so as a society, we're becoming more anhedonic, which then makes it harder for us to diagnose clinical depression, because is your lack of pleasure, is it because you're just getting bombarded by dopamine, or do you have a clinical illness? So someone's asking, what's the difference with an SNRI and an SSRI? So an SNRI is a serotonin norepinephrine reuptake inhibitor. So an SNRI works on two neurotransmitters, serotonin and norepinephrine, and an SSRI works on one neurotransmitter, which is serotonin. So this once again goes back to this hypothesis of, depression as a neurochemical serotonin deficiency. We know that SNRIs are just as effective as SSRIs in treating depression. And so it sort of suggests that, whether I'm working on serotonin and norepinephrine or just serotonin, the clinical effect is roughly the same for people, right? Which suggests that there's more to depression than a serotonin imbalance or deficiency or things like that. So this is what I'm kind of saying, is that clinicians kind of know that the neurochemical imbalance hypothesis is it's just a hypothesis. And I think what really propagated the neurochemical hypothesis is not actually core scientific studies where people are measuring serotonin concentration in the synaptic cleft. This theory was really propagated through the efficacy of SSRIs and kind of reverse engineering. If this medication works, that must mean that there is a serotonin deficiency. The other reason that it gets propagated is because of the stigma, because it really helped us sort of no longer blame people with depression, because if it's a neurochemical imbalance, you can't control that. That doesn't mean you're lazy. It's good. So a lot of people are pointing out that SSRIs aren't the only antidepressant medication. Absolutely, right? So this is the challenge that we face on stream, which is that we have to balance being succinct with being complete. So if you guys want to know everything about SSRIs or antidepressant treatments and medication, you can go get a pharmacology degree, you can become a pharmacist or a medical doctor. And there are lots of different treatments, right? There are also these things like mirtazapine, SNRIs, SSRIs, even our third generation, sometimes antipsychotic medications like aripiprazole and stuff like that will have supplemental effects for depression. There are all kinds of medications that have been used clinically for depression. We're just sort of focusing on first-line treatment, which is usually an SSRI. Is this video pre-recorded or live? It's live. Okay, so someone's asked, I guess these are some questions about what do you do if you identify that it's PTSD and not depression? Then you treat the PTSD, right? So there are treatments for PTSD where from a pharmacologic standpoint, we have medications that will manage some of the symptoms of the PTSD, but they're not going to they'll manage things like nightmares and sleep, but they're not going to manage the core of the trauma, which almost always requires psychotherapy or some other kind of processing. So some people will overcome trauma without any kind of clinical treatment, right, through their own healing journey and stuff like that. But from a clinical standpoint, if you have a diagnosis of PTSD, usually psychotherapy is what it takes to fix it. Wow, so many questions. Okay. Man, so many good questions. Okay, so I think I'm going to put together a lecture on depression. I've decided. Okay, so someone's asking a question about how to come off of SSRIs gradually or cold turkey, and what's the problem with cold turkey. So this is important to understand. Anytime our body regularly ingests a psychoactive substance, if we stop cold turkey after our body has developed a tolerance to it, we may experience a withdrawal. So this is not just for SSRIs, but I want y'all to think about something like caffeine, right? So if I drink coffee every day and I just stop cold turkey, what's going to happen? I'm going to experience a withdrawal. Is that withdrawal going to be life-threatening? In the case of caffeine, almost certainly not, right? But it's going to make my life really, really rough. So even in the case of caffeine, you can taper off of caffeine without experiencing bad withdrawal. In the case of some tolerance and withdrawal, it can be life-threatening. So if I am a chronic alcohol user and I've developed a physiologic tolerance to it, if I stop alcohol cold turkey, that can be a life-threatening emergency. So withdrawal from alcohol can actually be fatal if you don't manage it properly. In the case of SSRIs, once again, not fatal or anything like that, generally speaking. But what we can do is your body and brain have gotten used to this chemical being there. And if you stop it cold turkey, the adaptations that your body and brain have made will be like left in a lurch. And you can go through some amount of withdrawal or other kinds of symptoms. So that's why it's important to sort of taper off of it under the guidance of a clinician. So someone's asking, how bad is it to have gone through all those medication options without healing? That's an interesting question. And how bad is it? I'd say that depends. So when I see people who have treatment-resistant illnesses, some people may look at that and say, oh my God, this is a treatment-resistant illness, you're screwed. Whereas sometimes the reason that multiple trials of antidepressant medication don't work is because the underlying diagnosis is incorrect, right? So we were talking about trauma earlier. Like, this is a prime example. I've seen patients who will have had 6 antidepressant trials. And after, the 6th one doesn't work, we kind of start scratching our heads and we go back through the diagnostic process. We reassess them. And it may seem like, oh my God, 6 medications haven't worked. This person is screwed. Whereas that's actually really important information to make the right diagnosis. And once you make the right diagnosis, then you can start on your path of healing. And sometimes people will get better, right? Because now that we know that it's not major depressive disorder or bipolar disorder, now we can actually fix what the problem is. So that's where, I work with a lot of people. Like, historically, people come to me who are treatment resistant. So I have this emphasis on complementary and alternative medicine and like evidence-based CAM, right? So what sort of works and what doesn't work. And so I would get a lot of consults and patient requests from people who are like, nothing has worked for me. I want to try something in the alternative medicine category. And so I've worked with a lot of people who have treatment-resistant depression, and I've actually seen pretty good outcomes with those people. It just means okay, let's go back to the drawing board. Let's really try to understand diagnostically what's going on. Let's try to understand where this depression is coming from on a biological level, on a psychological level, on an environmental level, right? Are you depressed because you live in a toxic home environment where every day you go home and there's just toxicity, 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 toxicity? SSRI isn't going to fix that. Even on a spiritual level, right? So for some people, they'll sort of really identify with kind of a spiritual perspective on depression. And so even as we approach all those different perspectives, we can really move towards healing, and medication can be just one piece of that puzzle. So someone's asking, is it possible to come off of depression without using SSRI or other drugs? Absolutely, right? So a couple things to remember about our current understanding of depressive episodes. Number one is that depressive episodes in things like major depressive disorder and bipolar disorder are actually time limited. Okay, so this is something that a lot of people don't understand. So a depressive episode means it ends. So even if you don't treat people with bipolar disorder and major depressive disorder, most of them will actually come out of the depression on their own. It's an episodic illness. Now, for people who have chronic depression for years and years and years, they may not actually have a diagnosis of major depressive disorder. They may get diagnosed with it originally, but it may actually be something else. Okay, so there's dysthymia is another diagnosis that you can have, which is a persistent state of low mood that doesn't fluctuate as much. So the diagnosis could be different. So for a lot of people, they actually come out of depression kind of on their own, but they suffer a lot and for a long time, and it can sometimes negatively impact their life in pretty profound ways. So you don't need medication. And that's also where studies show that psychotherapy and medication are roughly equally effective, right? So it's a lot of people come out of it with psychotherapy And there's even some evidence that we sort of suggested earlier that the benefits of psychotherapy will last longer than the benefits of medication. Blue Official is asking, but chemical imbalance now has been proven wrong according to you, so the fault is the depressed person. So we have to be nuanced with this, okay? So first of all, it hasn't been proven wrong. So all we've done is look at the evidence, and based on the evidence that we have, it does not seem to support that hypothesis. That being said, very few of the studies, or almost none of the studies that are cited in that review, are looking at synaptic concentrations of serotonin. So it could be true, but what they're measuring is like blood levels of serotonin, which is like very different, right? So we just don't have good ways of measuring serotonin within the brain. So does that mean that it's the fault of the depressed person? No, it still could be an organic process. It's just, we just don't know what it is. So it may not be a serotonin imbalance. It may be an imbalance of other neurochemicals. Chances are it's a more complicated process, like things like hyperactivation of the default mode network is common in depression. There's a lot of other reasons. It's just not that one, right? We also know, for example, that there are genetic components to depression. So there's like some amount of heritability there, heritability, which is, so it doesn't mean that it's the person's fault. It doesn't have to be either or. It just, we had one prevailing theory for why people get depressed. The mechanism of that theory doesn't seem to have a whole lot of support, but there are 1,000 other things that may not be the person's fault that could be going on in their body that, like, you know, it's not their fault. We'll talk about fault and depression in a second. We've got a really good post. Maybe actually now's a good time. Okay. Okay, let's, so someone's asking about diet and depression. So this is a really interesting topic, like diet and depression. The short answer is, like, we could do a whole lecture series on it. So here are kind of a couple of different approaches that I take. The first is we talk about diet and depression a lot in Dr. K's guide in a very detailed way. There are a couple of different perspectives. So we know that there's some evidence-based stuff, right? So things like vitamin D deficiency, for example, contributes to depression. I think there's, you know, evidence that high amounts of omega-3 can be helpful. Sometimes making sure you get good levels of like B12 and folate and stuff like that can be helpful for depression. So we do know that there are some dietary supplements and things like that, that if you're deficient, supplementing and fixing can help with depression. That's kind of good evidence. Generally speaking, we know that eating lots of fruits and vegetables, high fiber diet with minimally processed foods tends to improve just about all physical and mental illnesses, right? So just like eating healthy in general, it ain't shocking. As a clinician, sometimes I'll have patients go on a more Ayurvedic diet based on their dosha. And what I've found is that patients who adhere to Ayurvedic diets tend to be, it's easier for them to come off of medication than patients who don't. Now, we've got to be super careful with that observation, because one conclusion is that the Ayurvedic diet does help with depression, although we don't really have good scientific studies to suggest that at all. The other kinds of things that we have to consider is that if you're able to adhere to a good diet, maybe you're less depressed in the first place, right? So the more depressed you are, like, the harder it is to, like, not eat frozen pizza. So, like, there could be all kinds of correlations that we've got to be super careful about, where maybe the healthier people are the ones who can make the dietary changes. There could just be something about the discipline of making a dietary change that leads to an improvement in depression that has nothing to do with the Ayurvedic diet. So it's been my observation that adopting the right kind of diet, and that's where I think what's going on is that the Ayurvedic diet affects your gut bacteria. And as your gut bacteria change and become healthier, we do know, for example, that there are particular gut bacteria that lead to less depression, and there are particular gut bacteria that lead to more depression. And one way to potentially alter your gut bacteria is through a dietary change. And there are also some really interesting studies on, for example, stool transplants and remission of depressive symptoms, mostly in animal models. So we do know that diet and depression is correlated. The tricky thing is that there's some strongly evidence-based stuff, But in my experience as a clinician, there's other stuff that seems to work really well, which the science, we don't really understand how it works or even that it consistently works in clinical trials for the average person. But if y'all are curious, you can learn more about Ayurveda and stuff like that and then have a discussion with your doctor about it. Yeah, so for people asking, like, one of my friends told me that 90% of the help he got was from diet. What diet would you recommend for depressed people, or do a lecture? So we have a lecture. That's why we kind of go into the nuance in Dr. K's guide. So definitely check that out. And that's where, in my experience as a psychiatrist, it is not a diet for depressed people. It's acknowledging that depression manifests in different people in different ways. And the same diet doesn't work for all people. Because depression, we may call it, we use one word to encompass it. But we know, for example, there's unipolar depression and bipolar depression. We know that there are even different kinds of subtypes of depression. There's an anxious depression, a neurovegetative depression, depression with anger attacks. So we have these different, subtypes of depression, and I think you probably need a tailored diet depending on your subtype and your particular situation. Yeah, so you guys have a lot of good questions. So we cover a lot of this in Dr. K's guide. What about natural alternatives? So first thing to understand is that just because something is natural does not mean it's safe, okay? So like, poison ivy is natural. Doesn't mean that it's safe, right? There are all kinds of like snake venom is all natural. Doesn't mean it's safe. So we've got to be super careful when we, focus on natural stuff because a lot of natural remedies can be toxic. Another thing to be concerned about natural remedies, and this is as someone who uses a lot in my practice, okay? I use a lot of natural remedies, is that the consistency of the product is like high, they're not consistent at all. So there's no amount of regulation. No one is testing this stuff. There was a paper by, I think, Dr. Saper in 2001, y'all can look it up, where a group of psychiatrists, or I don't even know if they were psychiatrists, maybe just doctors, tested natural supplements. So they just went to the store and they bought like 15 different bottles of stuff. And what they found is that more than half of them contained way less or none of what they claimed to contain. Right? So there's no regulation. So the good news about medication is that it's like regulated, right? So you can't sell something that's an SSRI unless it's the actual SSRI. There's quality control and quality testing. So you've got to be super careful about natural remedies. The other thing is that some natural remedies do seem to help, but generally speaking, the quality of evidence for a lot of it just depends on the natural remedies. So we actually have also in Dr. K's guide, we go through a lot of different natural remedies and the evidence to support them and sort of what seems to work and what seems to not work. So, good questions. Okay, let's move on. Man, so many questions. I got stuff to cover, though. So, for people who are talking about homeopathy, yeah, so I don't think the evidence for homeopathy is great. So that's why usually when I recommend things, like if people want to see alternative medicine practitioners, I'll usually recommend they consult with someone who's from the Ayurvedic or Chinese medical system, because I think those have the most evidence behind them. We also know, for example, that some of our best medications are derived from herbs from these two traditions. So turmeric and its anti-inflammatory properties comes from Ayurveda. Ashwagandha comes from Ayurveda. All of our statin medications come from Chinese medicine, right? So we know that they do use herbs that are, in our case, blockbuster drugs. And basically what happens is a pharmaceutical company will go and research this stuff, purify the compound, and patent it. Okay. Psychedelic studies are really promising? Yeah, that's what they are, is promising. So let's remember, there's a difference between promising and definitely effective. So I'm optimistic. I think, the work that Rick Doblin and the folks over at MAPS are doing is fantastic. Like, I think there's a lot of good promising, benefits of psychedelics. Okay. Let's take a look at a couple of other things. Okay, synaptic cleft. All right, so we're going to take a look at a post. Next up. Okay. So, am I the asshole for telling my husband I'm sick of his depression ruining our lives? I, 26F, and my husband, 28M, have been together for 8 years. We love each other deeply, and I'm still madly in love with him. Both of us have struggled with depression our whole lives. I would never judge him for something like that. My problem is this: he does not in any way try to treat his depression, so he keeps going through a cycle of self-sabotage. He cannot hold a job. Since the beginning, he's had a pattern of getting a job, doing extremely well for a while, feeling good and happy. Then it always falls apart. He calls out one time, then it spirals. Suddenly he's calling out or showing up late 3+ times a week, then sometimes daily until his bosses have to let him go. Every time I go into a panic mode, working overtime at 2 to 3 jobs and taking out loans to keep us afloat while he drags his feet to find another job. Then he finds one and the cycle starts all over. He does great, we catch up on bills, I feel like I can breathe, it all falls apart again. Each time he gets fired, I tell him that it's going to be okay and that I will support him. The last time he was jobless, I was working 2 full-time jobs and had to sell my car to pay rent and his car payment. I was devastated, but I never cried in front of him. That was a year and a half ago. Then he got a great job. He started kicking ass as usual, and I loved it. A year in, I felt a bit of relief. I thought this one would stick, and I could see the light at the end of the tunnel. Then 3 months ago, the cycle started over. He went from being a wonderful employee to calling out twice a week, showing up late daily, and barely showering once every 10 days. One day, he decided not to go into work 20 minutes before he was supposed to be there. I got a horrible gut feeling and pleaded with him to please not lose this job, that things were better, but we were still on shaky financial ground and that I needed help. He shrugged it off, told me that his bosses loved him and would never fire him, and texted that he wouldn't be in. Sure enough, he was fired. I lost it. I started sobbing and yelled that I could count on one hand the number of days I had had off in all our time together, that I couldn't believe he had done this again. He said that it was my own fault for never taking days off and that my depression isn't as bad as his, so I wouldn't understand. I told him that I couldn't take any days off because one of us has to make sure we don't end up homeless. I sobbed about the pressure I was under to always be the stable one and to never acknowledge my own struggles. He said I was acting like his mental illness was his fault. I said that the depression is not his fault, but the fact that he doesn't treat/manage it is. That I love him, but I'm so sick of his depression ruining our lives. I said I have nothing left to sell, and there was no way I could get another loan, so without his income, we're going to lose our apartment. He told me to F.O., which I assume means screw off, with my blaming verbal abuse and stormed out. Now he won't answer my texts or calls. I need to know. Am I the asshole? So, sometimes we look at posts like this on the internet. And when we look at posts like this on the internet, it's very easy to say, oh my God, you're not an asshole. You should dump him. You should move on. Like you're totally within your rights. For 8 years, you've been supporting someone with depression. And then the challenge is that, like, when you're in a relationship with someone with depression, like, you don't want to be mean, right? You want to be compassionate. You want to have understanding that, like, this isn't their fault. Like, having the depression isn't their fault. And then, like, if you try to, like, point it out to them, if you kind of, like, try to get your partner to take accountability for the depression, it's verbal abuse. It's like, you don't understand how bad I have it. Easy for you to say, right? So, like, it's kind of weird because depression can almost become like an invincibility potion against criticism from someone in your relationship. And if you break up with this person and you move on, right? So, like, you're sharing your side of things with the internet, where who knows what the actual truth is, right? You're looking for, like, validation from a bunch of strangers. And so you, like, it's your perspective on things. And then if you actually break up with this person, they go to social media, they share their side of things. Oh, like my partner, like I've been struggling with depression for a while and my partner dumped me because of my depression. Because you want to be a good partner, right? It's like, especially if you're married, it's presumably death till death do you part, and you don't want to give up on your partner. It's not their fault that they're depressed. And yet you're at the end of your rope. So what's going on here? How do we know what someone with depression is responsible for and what they aren't responsible for, right? Like, how do we know, like, when is it compassionate and when is it mean? How much patience should I have? How many second chances should I give this person? Because the thing about depression is, like, it gets in the way of people taking care of themselves, right? So it's like, how do I know if they're not doing something? Is it lazy or is it depression? And the tricky thing is that if it's depression, are they ever lazy? Like, is it possible for someone to be both depressed and lazy? And how do you tell the difference? So it's really challenging to be in a relationship with depression, with someone with depression. And what I'd love to do is lay out a couple of basic principles, actually share with y'all some potentially mind-blowing insights about the correlation between lazy and depression. Because one interesting thing that's happened is that as people become more aware of mental health issues, mental illness issues, we've actually as a society become more understanding. And as we've become more understanding, it's had some interesting effects. And so we're going to look at some really interesting research about laziness and depression. And then we're also going to try to frame things for y'all in terms of like a couple of tips about how to have conversations and how to think about this if you're in this kind of relationship. So the first thing that we're going to talk about is psychogenic seizures. Let me see if I can take a look at this. So sometimes people have a diagnosis of something called epilepsy, okay? Epilepsy is like a seizure disorder. So you have this abnormal electrical activity in your brain, and it basically causes a seizure. So we also know that there's something called psychogenic non-epileptic seizures. So what this means is like basically fake seizures. It's someone who pretends to have a seizure. Oh my God, I'm seizing. And it's not a real epilepsy, but like it looks like a seizure to some people. They kind of act like they have a seizure. And so this paper is looking at the incidence, which is how commonly do people get psychogenic non-epileptic seizures. So this paper looks at the incidence, and it's 3 out of 100,000. So if I take a group of 100,000 people, 3 of them will develop psychogenic non-epileptic seizures, essentially what we call, kind of you can think about as fake seizures, right? But there's a really interesting finding. So 3 out of 100,000 isn't very much. Very rare. But 25 to 40% of people who have psychogenic seizures also have real seizures. Which is kind of interesting, right? That's bizarre. 3 out of 100,000 in the regular population. But very, very high comorbidity with real seizures. So what's going on here? One of the really interesting things is that when someone has seizures, they subconsciously discover a couple of really important things. They discover that if I have a seizure, I get excused from stuff. Oh, I didn't do my project? If I have a seizure, I can get more time. I don't feel like going to a party. If I have a seizure, not my fault. I'm applying to college and I'm afraid that I'm not going to get into a good college. If my seizures get bad, then I have an excuse why I did not get accepted to the best college in the country, because my seizures got in the way. So it's kind of like a devastating thing to think about, right? So like here I am, I'm saying, oh my God, like, oh, is what I'm saying cruel? Is it unusual? This is a fact. That people who have real medical illnesses will subconsciously learn how to use those illnesses to meet certain psychological needs and get excused from responsibilities. Now, I'm not saying that everyone with seizures does this, right? So this is like somewhere between a fourth to half of people who have psychogenic seizures will also have real epilepsy. And it turns out that there's literature on this. So then the question is, can that be true of depression? Can someone who has real depression fake their depression to get excused from stuff, like paying bills and going to work? And it turns out that the answer is yes. So this is an area of research which is growing, but we actually don't have really good numbers. But what we know is that sometimes people who have real psychiatric illness will also fake psychiatric illness. And it turns out that there are a couple of interesting hypotheses for this. So this is where I'm just going to read this out a little bit, okay? Malingering is an adaptive response. This model proposes that malingering represents an adaptation to hostile circumstances. According to this model, there are two broad dimensions of malingering: cost-benefit analysis and adversarial setting. Malingerers perceive the environment in adversarial or risky terms, and malingering is seen as a behavior which maximizes the chance of success in such a situation. Now, malingering is a slightly different diagnosis for a couple of different reasons, but the key thing here is that we actually have, some interesting papers about how people, when they're faced in adversarial situations, i.e., my partner is yelling at me because I'm not doing what I'm supposed to be doing, what's the cost-benefit analysis? How do I maximize this situation? Like, how do I go 8 years in a marriage without taking responsibility for my mental health? I cite my depression. So this is what's so tricky about this kind of thing, because are they faking it? Well, the answer is possibly sometimes. 20 to 40% of people with psychogenic seizures also have real epilepsy. I'm not saying that everyone with depression does this kind of thing, but we do know that some people actually do it, right? And this is where, as a psychiatrist, it's a real struggle for me too. Like, how do I know when a patient just doesn't show up for their appointment? How do I know whether it's depression or they're just feeling lazy that day? And even the person, we have to remember for a moment that a lot of this is subconscious. So the person themselves may not know. So the tricky thing is that when you have a diagnosis that gives you excuses in life, it's very, very easy as a human being to start leveraging that excuse. And this is what's so frustrating about being in a relationship with a person like this, is that you're trying to be compassionate, but in the back of your mind, you sense the BS. You're like, this isn't always depression. There is actually more you can be doing, but you're not doing that. And the problem is that if you hold people responsible to that, that's when they come back with oh, you're verbally abusing me. You don't understand how bad my depression is, et cetera, et cetera, et cetera. Right? They play their trump cards, which is that you are not sensitive to people with mental illness. It's devastating. And what do you do in that situation? So let's try to understand how to approach this, okay? The first is that I'm a big believer of this statement that mental illness is not your fault, but it is your responsibility. So the way that I kind of think about this in terms of whether I quote unquote blame someone or not, right? So this is a very individual approach, but here's a kind of general rule of thumb: is not how you behave when you're depressed. It's how you behave when you're not depressed. This is what I hold people accountable for, right? So if someone is depressed and they miss an appointment, that's okay. But if they're missing appointments, once they start to get better, that's actually on them. That's not an excuse for depression. So this is where a lot of people who struggle with depression, they'll have episodes, right? They'll come in and out of it. The real question is, how seriously do they take it when they're not depressed? So if I've lost 5 jobs because of my depression, and then I start to feel better, I need to be in therapy. I need to connect with a psychiatrist, even if I'm feeling better, because I need to protect against the next episode. And this is what's actually so devastating, is that a lot of people who are depressed or suffer from, a depressive disorder basically have the hope-based strategy. So this is what I call the hope strategy, which is when you ask them okay, what's going to happen a year from now, 2 years from now, 3 years from now? What's your strategy to deal with the depression? And what it comes down to is basically, I hope it'll be okay. Like we heard it from this person where like the partner expresses concern, hey, maybe your bosses are going to fire you. Oh, no, they love me. I hope it'll be okay. I'm not going to do anything actively about it. I'm just going to hope for the best. If you've lost 5 jobs, well, like, I just hope it'll stick next time. Like, I'll figure it out eventually, right? It's just like, there's not a concrete strategy. It's just like hoping that things go away and fix themselves. And so if you're someone who's in a relationship with someone who's depressed, or you yourself adopt this attitude, which is, by the way, it's sort of not your fault, right? Because when you struggle with depression, the hope is what sustains you. Does that kind of make sense? Like when you're struggling with depression, what you start to do is start to like develop this idea that, okay, like tomorrow, a better tomorrow will come, a better tomorrow will come, a better tomorrow will come, a better tomorrow will come. And that's what sustains you through the dark times. And then the better tomorrow comes, and that sort of becomes the whole of your strategy. So this too, what we have to understand about these adaptations, right, is we're not trying to blame the person or even the hope-based strategy. There's a reason why people have those strategies. And also, just because they have a good reason for this adaptation does not mean that it can't become maladaptive. And this is what we tend to see in relationships like this. So if you're in a relationship with someone like this, you start to do the heavy lifting as an adaptation to survive, right? Oh, my partner lost their job. I'm going to work 2 full-time jobs because I have to adapt to my circumstances. And over time, that becomes a maladaptation because the more lifting that you do, the less lifting they have to do. So then, like, when they start working again, are you quitting your other job or do they just start to rely on you more and more and more? Like, what's going on here? Right? So you can do all of the right things in the moment and still end up in the wrong place. And if you're having trouble with someone if you're dating someone who suffers from depression, I think you should absolutely be compassionate. I think you should absolutely be understanding. I think you should absolutely try to do the heavy lifting when their times are down. And also, they should be responsible for what comes tomorrow. They should do everything within their power, whether they're feeling good or not feeling good, to prevent the next depressive episode. And so that's where the real emphasis is. It's not like what you get, do whatever you need to survive today. But once things start moving in the right direction, what amount of commitment is your partner willing to make? Or if you were in that situation, what amount of commitment are you willing to make to never put your partner in that situation again? That's the key thing. Because hoping that you never get depressed and, oh, this time it'll be different, like why? What makes you think that? And what you realize is it's just a hope. There's nothing to it. So last thing that we're going to kind of do is talk a little bit about how to have conversations with your partner who suffers from depression. So this is where I think there are a couple of simple questions, right? Which is like starting off with trying to understand what's your understanding of depression. And what you want to try to do is develop sort of like an expectation of what's going to happen and what we're going to do if particular things happen. So we want to go through sort of like a set of contingencies. So if you're feeling better, when you're feeling better, like, are you planning on engaging in treatment? Yes or no? If yes, why? If no, why? Help me understand what is the role of treatment in depression. And if you don't engage in treatment, what do you think is going to happen? And if that happens, or if something else happens, then how are you going to adjust? And if you don't engage in treatment, what are you expecting from me? What are you signing me up for if you don't go to treatment? And this is where they may use the hope-based strategy. I'm not signing you up for anything because I'm going to conquer it this time. It's not going to happen again. I would never put you through that. What is your plan in terms of making sure that that happens? Willpower. I'm just so sure. Right? So you want to have these open-ended conversations about expectations. What do they think is going to happen? You're not going to tell them to do something or tell them to do something else, right? You can. We'll get to that point in a second. And that's when you start to establish your boundaries. Right? And you can say, like, I see where you're coming from, but as someone in chat, as Athena Almighty said, this time. We've been through this rodeo before and you haven't gotten treatment. I can't continue to do this. What are you expecting me to do when you get depressed again? It's happened 5 times already. What are you expecting of me? What does this mean for the number of days off that I have over the next year? What does this mean about our finances? Like, I'm trying to plan and build a life with you, and I need help answering these questions because I can't answer them on my own. And when you have conversations like this, people may feel attacked. They may feel like you're verbally abusing them, which, if we look at this post, it sort of sounds like this person was quite emotional, right? So that's why, like, you need to emotionally process before you sit down and have this conversation. The good news is that if you kind of keep chill and you sort of process some of your emotions and you really approach it problem solving, they may still play their adaptive defensive cards. This conversation is making me depressed. Okay, I understand that. I'm sorry it's making you feel that way. I still don't know how to plan a life with you without having this conversation. What would you recommend instead? So you want to be solution focused, not blame focused. It's like, okay, if this doesn't work for you, like, how do we plan? Right? And it's actually like really devastating to have these conversations with someone who's depressed. Because when you don't blame them and you're trying to move forward, they kind of don't have a safety blanket. Because if you get angry with them, if you start blaming them, then they can play all their defensive cards. Oh, no, you don't understand how bad I have it. Oh, no, that's fine. You just tell me how bad you have it. Like, I'm not blaming you. That's why I'm trying to figure out, like, how do I plan a future with someone who is this depressed? And that makes them feel more depressed. Because it's like, oh my God, this person, like, my partner can't, like, I love them, but they can't plan a future with me. And that's sort of like, okay, so, like, if you feel that way, like, let me know. Does that make sense? This is another thing we have to be really careful about, is that sometimes I'll see this, people are talking about this, which is like, how do I keep my partner from not being suicidal? How do I share any kind of feedback with them and them, like, becoming suicidal? So if you're in a relationship with someone, I want you all to understand something. Suicidality, do you influence it? Sure. But suicidality can sometimes be used as a form of emotional manipulation. Right? It's like a trump card to avoid particular topics. Oh, this is making me suicidal. I guess we can never talk about it again. So that's where, like, sometimes, especially we'll see this sometimes in, like, romantic relationships and stuff, where people will, like, threaten suicide. Like, if you break up with me, I'm going to kill myself. And then what happens, something very subtle happens, is that if you're in a relationship with someone who uses suicidal blackmail to keep you in the relationship, you feel responsible for their behavior. You become responsible for their behavior. They say, hey, the responsibility for my mental health is now controlled by your actions. I wipe myself of all responsibility for my own mental health, and it's now on you. Take it. And then what we do, because we're terrified by suicide, we're like, okay, I'll take it. I'll protect you. I'll never break up with you. I'll be here for you always. And then the other person subconscious is like, well, shit, this works great. I can't do the dishes today. It'll make me suicidal. And so it's tricky, but I think that it's very important to remember that suicidality is really the responsibility of the person. And also of their treatment team. Right? If your partner is suicidal, like, that's not something you can fix. And even if you're a mental health professional, like, that's not something you're supposed to fix. It's conflict of interest. But this is what's so difficult about being with someone who sometimes struggles with depression. And if you're someone who struggles with depression, you see these kinds of patterns, I get that it's hard. Like, I'm not, in a sense, blaming you for this, but I think that you have to accept some degree of responsibility, because if you have no degree of responsibility, you have no degree of power, then you can't actually fix it. And this is what's actually so devastating about it, is by absolving ourselves of responsibility, we also remove the power from our own hands. So even if I, like, queue up for a video game and I say, I can't do anything to win this game, it all depends on my teammates, I'm just going to AFK and hope that I win. You may win some, you may lose some, even if you exert no effort, but by giving up your own power in that situation, you're actually like, you're absolving yourself of responsibility and removing your own power. And that's where I think in this kind of relationship, what the person needs to do is start accepting responsibility for their mental illness. It's not fair, it's not my fault, but it is my responsibility. And practically what that oftentimes means is engaging in a very, very strong treatment plan, not only when you're depressed, but also when you're feeling well. Because here's the thing, when you're feeling well for a while, something tips you off, right? Something like triggers the depression. There's some amount of emotional suppression or work-related stress or something else, even physical illness, that will trigger the whole cycle again. And so you need to be well ensconced in treatment when those kinds of challenges arise so that they don't knock you completely off your game. So just to summarize, it's really hard to be in a relationship with someone who struggles with mental illness. The tricky thing is that sometimes people who struggle with mental illness will also use it as an excuse to absolve themselves of responsibility. And then the tricky thing is that we're stuck with this very, very careful balance of how do I be a supportive partner and not be mean and lack compassion for someone who struggles with mental illness versus how do I get this person to take responsibility for their mental illness? Because I can't carry for both of us. I've been carrying this relationship for 8 years. I can't do it on my own anymore. And then the really challenging thing is that even if you try to talk to your partner about it, even broaching the subject can result in allegations of verbal abuse and a lack of support and it's not my fault and you're blaming me and all this kind of stuff. And then you feel bad, right? Because you feel guilty for thinking these things in the first place. And then they say it to your face and then you kind of feel hurt and then you're never going to bring it up again and the cycle perpetuates. So what do you do about this? Conversation, conversation, conversation. Talk to them. Try to get a shared forward-thinking approach. Okay, what are we going to do about this? It's not your depression. It's not my depression. It's our depression. What are my contributions and what are your contributions? I need to understand what to expect from you. I need to figure out what to expect from myself. What amount of responsibility are you going to take and what amount of responsibility am I going to take? It's not about blame. It's not about you're not taking enough or you're not doing enough. That'll trigger the defensive response. Right? And the key thing to remember is that if you're in a relationship with someone and you love them, I know the internet is almost certainly going to tell everyone to dump this person. But if you're in love with someone, then you need to help them build a relationship that is worth being in. That's the goal, right? How do you make this work? Because people in this situation want to make it work. The thing is, you just can't make it work on your own. You need their help. And that involves a conversation. So talk about expectations, talk about long-term plans, talk about strategies and contingencies, like what are we going to do if this happens? What are we going to do if this happens? What are we going to do if this happens? What can you expect from me? What can you not expect from me? What can I expect from you? What can I not expect from you? And if things don't go as you hope, what do you need to do to fix it? And this is what's really important. When they're well, when you guys lay out this plan, if they make excuses, then you're in trouble. If they don't hold themselves to if you don't hold them accountable and they don't hold themselves accountable, then the relationship is going to be in real trouble. And that's something that everybody needs to be crystal clear about. So it's tough. But I think one of the most devastating things that we can do in a relationship with someone who struggles with mental illness is assume that they're incapable. It's devastating. Just this is what we're saying, right? We're saying all along that just because you're mentally ill or you have a mental illness doesn't mean that you're less of a human. Doesn't mean that you can't be successful. Doesn't mean that you can't have a fulfilling life. There's all this positivity towards mental illness. What that also fucking means is that just because you have a mental illness doesn't mean that you can't accept responsibility, that you can't make change, right? If we're saying that mental illness does not make you a crippled person and horribly disabled, That also means that you need to grow up and accept responsibility. Is it challenging? Absolutely. Are we here to help? Absolutely. But it's going to require the person who struggles with depression's help too. Questions? Great questions. So I love these. So how does someone take responsibility on something like that? Like I said, I think for people who struggle with depression, the real responsibility comes when you're well. It's not about when you're sick. It's about when you're well. What do you do when you're well? Do you continue therapy? Do you start building healthy coping habits? Right? Because it's really hard to like start meditating when you're struggling with crippling depression. But are you going to learn how to meditate while you're feeling well? Are you going to continue to engage in therapy and learn like stress coping skills? Are you going to work on your deep set issues of shame and stuff like that? There's like kind of acute therapy, right? Psychotherapy for depression when people are like really, really struggling. And then like there's a second phase of psychotherapy for depression, which is like digging in and getting to the root of it. There's like putting out fires and there's rebuilding. So what taking responsibility is recognizing that when your town is burning down, it's really hard to do rebuilding at the same time. But once the fires are out, it's time to rebuild. That's where I really think that people need to take more responsibility. Or the ones who do well, I should say, are the ones who take responsibility during the good times. So that's kind of where responsibility starts. And how do I know how much power and control I actually have over my life? So this is really simple to understand. It's simple. I guess it's hard to understand. The power and control that you have is fundamentally only over one thing, which is your actions. You can't control what happens. You just control what you do. So in the case of this depression, it's very simple. What I control is whether I go to therapy or not. I don't control whether therapy prevents me from becoming depressed again. I don't control whether I make a breakthrough in therapy or not. What I control is whether I make an appointment with a psychiatrist and whether I go. I don't control whether the medication they prescribe works like a miracle or doesn't work at all. I can't control my own treatment resistance or my own biology, but I can control whether I try or not. And the trickiest thing about this is that since we're so outcome-oriented, our mind tricks us into complacency. Our mind starts to tell us, this won't work, so don't waste your time. Medication won't help me. It hasn't worked in the past, so there's no point in seeing a doctor. Therein lies the problem. Because sometimes what your mind does is keeps you from trying because it tells you of a particular outcome. And that's why what we try to do is encourage moving away from outcomes and focusing on actions. And it's hard, like it's very hard. Because it's not the way that our brains are designed, and even I struggle with it. But really all you control in life is your actions. Not what happens. So if you're struggling with depression, you don't control whether you get depressed or not. All you control is, do you go to treatment? Do you take your medication? Do you exercise? Do you eat healthy? Do you shower every day? Do you clean your room? Those are all the things that you control, only your actions. And be careful about that little voice in your head that says, don't bother because it won't work. Because I don't know if you know this, but you certainly can't see the future. And like, if you're listening to that voice, how's it going for you? Is it working out when you listen to that voice? Are you happy with your life when you listen to that voice? Because the voice says, don't bother. Save yourself the hassle. And the more you listen to that voice, what does your life become? Look at the outcomes of listening to that voice. It's trying to save you from pain and creating a life of it. Good question. So someone's saying, is it true that smarter people are more prone to mental illness? I don't think so. I do find that sometimes IQ can make things harder in some ways. Like, it's not a straight advantage. Generally speaking, it's an advantage, but like, I've worked with people who have anxiety where the number of calculations their brain is able to perform allows them to come up with more doomsday scenarios, which can be like devastating. This is a great question. How do you rationalize the BS happening in the world? Start by understanding that the BS happening in the world is a judgment that's created by your mind. The BS happening in the world is a rationalization that's already created by you. Right? Like, so people talk about how the world is going to hell. Like, oh my God, everything is so bad. And there are a lot of things to be worried about. Don't get me wrong. There's a lot of stuff that we need to be careful about. But most of the world is just proceeding like it always has. Right? Like, if I transplanted a random consciousness into this world for an hour and just walked around outside, it's not like everything is falling apart. So the first step in rationalizing what the BS happening in the world is to recognize that the BS is a judgment from here. So start by actually looking at your own thought process and how you conclude what, I don't even know what the BS is. Right? We have is Casimir saying there's a biased perception of reality. All of us have a biased perception of reality. So if you want to really understand what's going on and why BS is happening, you have to start with your own thought process. In fact, I think one of the biggest problems is that a lot of the leadership in the world today is not critical of their own thought process. They look at the world and they see all this catastrophe happening, and they start making laws and policies and things like that based on their perception of what's going on, whereas they're not critical about their own thought process. As we start to enter echo chambers and stop listening to like contrary opinions, the world becomes a worse and worse place, and the more extreme I have to become to balance it. So, I mean, I'm not saying everything is great, right? There are a lot of problems that we do need to fix, but a lot of stuff has gotten better. Like, it's pretty cool that I'm on the internet and I'm talking to people. Is it that thoughts are more important than actions, or actions are more important than thinking? So thoughts and actions go hand in hand. So if you want to control your actions, you can really start by controlling your thoughts. This is what a big part of Dr. K's guide to ADHD and doing stuff is about. Is the acknowledgement, like, let's start by like, where does action come from? Right? Like, ask yourself, like, how do you act? Whether you play a video game today or you work out today, like, where does that action come from? Right? So this is what I love about yoga, and this is what I fell in love with when I wanted to become a monk. Because there's a group of people who like figured out some very fundamental stuff, like, how do human beings act? What is the relationship between thought and action? It's not one-to-one, right? Because I think about a lot of things, and it's not like I do them. And then also, where do thoughts come from? And we kind of know this sort of, but we never sit down and really internalize it. Right? So we know that, for example, going to a bar every night versus going to an Alcoholics Anonymous meeting every night, in one of those situations, it's easier to drink, and in one of them, it's harder to drink. We kind of know that. But we don't take that fundamental principle understand the underlying equation, and apply it to every other dimension of our life. It is the person who perfects this that will become a yogi. That's what a yogi is. Is there an equation for life? Sure. You guys know what it is? Most fundamental equation for life? Maybe we'll meditate. So hyper successful people are yogis? Not necessarily. Okay, so I'm going to give you all a meditation for the fundamental equation of life. Y'all ready for it? So what we're going to do is listen, both chant and listen for the fundamental equation of life. Okay? The fundamental equation of life is Om. I know it sounds kind of weird, right? So like if you go to like mystical places and like new age bookshops, and like things that involve chakras and retreats, you will hear people say, Om. What is Om? Om is the fundamental vibration of the universe. The basic vibration of the universe. Ah, wonderful. What does that mean? What does that mean? So there's some people who claim that there is a fundamental equation of stuff. Like, what is the underlying equation for existence? They claim it's Om. So we're going to be kind of like, okay, what does that mean? How does that work? So when I was like studying to become a monk, like that's what I would ask. It's like I'd be like sitting in this ashram, right? Like stretching for a couple hours. I'd sit and I'd talk to this dude with a gray beard. And his hair tied up. All these prayer beads. He'd say, Om is fundamental vibration of the universe. Actually, I take that back. The actual swamis never said stuff like that. It's the people sitting in their classes that would say things like that. Right? It's the 28-year-old from some other part of the world who's come here to find himself, much like myself. Like, Om is the fundamental vibration of the universe. What does that even mean, bro? Like, what does that mean, fundamental vibration? So we're going to explore it, right? And see if we can figure this out for ourselves. So what we're going to do is we're going to chant Om. We're going to chant Om 3 times. And what I want y'all to do is pay attention to the sounds and the vibrations. And as we chant Om 3 times, we're going to pay attention to 4 sounds. I'll tell you what those are in a second. Then what we're going to do is go out into the world. And for the next week, we're going to see if there's anything that we can experience out there that sounds or feels like an element of Om. Okay? So we're going to see, like we're going to listen for Om in places. So here are the 4 syllables of Om. Ah, ooh, And this is important. After the there's a period of silence. Right? So as we breathe in, and then silence. And as we chant, we're going to do 3 rounds. Then we're just going to listen. And for those of you that are afraid to go out into the world, you can listen for Om here. Okay? So let's begin. So sit up straight, neck straight, back straight. Take a couple of centering breaths. Deep breath in. So that's a demonstration. I guess I should have told y'all that we're demonstrating once. So now I want y'all to do it with me. Right? So it's okay. So sit up straight. Deep breath in. And again, deep breath in. And one last time. Deep breath in. So when you're ready, you can come on back. And we're going to do a little bit of explanation. So, people are wondering, the hell does this mean? Fundamental unit of existence. When you're practicing, I want you all to focus on your experience of this. And I don't know how to say this, so this is going to make any sense. If you guys have done this for a little bit, it'll be easier to understand. Especially when you're silent at the end. There's like a stillness. There's just like, it's just existence. And the rest of life is piled on top of that basic thing. So an example is thoughts, right? So like, when you do Om chanting properly, you don't have any thoughts at the end. But if you think about like what's the most basic unit of existence, it's Om, then like when we're living our life, there are thoughts. And then on top of thoughts, we have hopes and worries and relationships and global trends and a resume and direction in life and favorite foods and not favorite foods and things that I like and things that I dislike and games that I like to play and games that I shouldn't be playing. Does that make sense? Like, life is just like a lot of this crap piled on top. But if we take away all that stuff, if we remove all gaming and all preferences and all global stuff that we're worried about, and even my own thoughts and my ambitions and all of those kinds of things, what am I left with? How much can I peel away what I think life is and just get to the most basic life? Like, what is like the simplest version 1.0, no colors, no sound, none of that stuff? And do y'all see how when you do that practice, in that silence, for a moment, all that crap is gone? And so if you want to know what's the fundamental equation that governs existence, chant Om. And then you'll begin to see that even as I go throughout my day, that's thoughts layered on top. That something underneath is the foundation of my existence. And I can layer thoughts on top, I can layer expectations on top, ambitions, preferences, relationships, all that stuff gets layered on top. This is the other thing that the yogis realized. All that stuff changes. My thoughts change. My emotions change. My relationships change. My ambitions change. All that stuff changes. And they started to ask themselves, okay, what doesn't change? And they figured it out. And then those people became yogis. And then they had disciples. And disciples asked them, what's the fundamental equation of the universe? And the yogis said, I can't explain it to you, but chant Om and you will understand. And that's how it works. So just sit in that existence, and then throughout your day, no matter what you do, try to see, is that fundamental silence, that fundamental existence, that fundamental, I'm calling it fundamental because that's been my experience, is that thing underneath everything else? And the more you spend time with this, the more you'll realize, like people ask, like, oh, it's the fundamental equation of life. Like it's a complicated thing. It's not a complicated thing. It just can't be perceived by the mind. It has to be experienced. And then it all makes sense. All right. Questions? So, Swabla was asking, the thing is the stillness after chanting Om, you mean? So in my experience, the stillness is where I discovered this. But you can focus on all three. You can focus on the whole practice. So when we chant Om, it's Ah, Ooh, in one breath, transitioning kind of evenly between those three. Ah, Ooh, and then silence while we wait to breathe again. How do you find the same thing outside of the practice? Excellent question, Irreverent Fox. So the first thing is you have to do the practice to become familiar with it. So let's say that, like, how do I find the taste of rosemary in different food? When there's like 15 spices in a particular dish, how do I find the taste of rosemary? Well, the first thing that I have to do is I have to taste rosemary over and over and over and over again and raise my ability to detect it by tasting just the rosemary. I'm going to try it today. I'm going to try it today until I understand the taste inside and out. And then what happens is I can taste one dish that has 2 spices, garlic and rosemary. Can you detect the rosemary? Yes. Then I'm going to taste a dish that has 3 spices, garlic and rosemary and chili. Yes, I can taste it. Now I'm going to taste something that has 4 spices, garlic and rosemary and chili and cumin. Can you taste it? Yes. And then so on and so forth until 15 spices, 16 spices, 18 spices, 20 spices. And what the yogis did is, as they tasted every aspect of life, they found there was one spice that was always there, and that is Om. Okay, a couple of questions. Is this just mindfulness? No. So I think mindfulness is a reduction of this. Mindfulness is a simplification of this. And at the same time, it is exactly the same. Generally speaking, I think this degree of kind of esoteric philosophy tends to be denuded from mindfulness. They kind of removed all this stuff. But you can still get there 100% with mindfulness. Second thing, someone's asking about self-inquiry like Ramana Maharshi to uninstall the default mode network. I don't know specifically about that particular guru or their plan, so I can't recommend it. But generally speaking, meditative practices and mindfulness practices appear to have the effect of disarming the default mode network. Is this from the Mandukya Upanishad? I don't know if it's from the Mandukya Upanishad, but I wouldn't be surprised if it is represented within the Mandukya Upanishad. Krishnamurti is good, I think, for people who are asking. Who are you rating today, by the way? What do y'all think? Do y'all want to raid? We'll answer questions as we sort it out. Ruby Rose. Oh, Ruby True is streaming. So let's raid Ruby. Y'all can do some nice ASMR and yeah, y'all can do some nice ASMR and reflect on some of these things that we're talking about. All right, take care, everybody. We'll see y'all on Wednesday.